So welcome to the State EMS Conference with EMS Challenge. My name is Will Ferguson. I got a clicker somewhere. So we'll be streaming this live. We usually have about 200 participants online. If you have a question, raise your hand. We'll bring a mic to you. I try not to be too inappropriate as well, but we'll get started. Yes, sir. Oh, yeah. So if you're in the vendor area, kind of try to keep it down. We are streaming live. We've got mics, so that may kind of feed over. So if you could just help us out, keep it down just a little bit. EMS Challenge started 7-8 years ago with the purpose of bringing physician-led Con Ed to the providers. Years ago when I was doing EMS, it seemed like there were many physicians involved. That seemed to kind of go away over the years. So I'm trying to bring that back. And the goal of this is quality, relative, practical Con Ed delivered by docs that's free to you guys. So that's the purpose for that. But we do second and fourth Wednesday. We do lectures and skill labs. The Fire College is a sponsor for the past several years. They go on the road with us. So that's the purpose behind EMS Challenge. If you would, online, we also put in the Dropbox, a chat box, a way to get the Con Ed today. For the guys here, if you'll scan the QR code, either use our Con Ed, if you would, and then the certificate, and that way we kind of got feedback of what's going on. So online, if you need your Con Ed certificate, email us today as well. If you can't get the QR code to work, just get it to us this afternoon. Upcoming events, we're going to be at Springville Fire Department in December, Birmingham Fire every other month starting in January. We're also in Trussville throughout the year, and we should be at the Super Speedway sometime in the spring, waiting for confirmation. So one of the big pushes that I'm trying to do is 12-lead EKG interpretation. When paramedicine came about, medics were taught 3-lead interpretation. We're the gurus of that. I get that. Junction rhythms, tachycardias, VTAC. But years ago, when paramedicine was started, we didn't do much for heart attacks, right? So if you had a STEMI, you had a big heart attack, we said, yeah, you had a heart attack. Quit smoking, here's some bad food, we'll watch you in the hospital, hang some lidocaine. We can actually fix STEMIs now, right? With cath abs, with lytics. So there's a big need to understand 12 leads. And I know I harp on this at least once a month, but I think it's pretty important. 12 leads should be a screening tool. Don't get complicated. I know there are vectors and things like that to learn, but it's pattern recognition. And that's what saves me at 2 in the morning when I'm really tired, I've been working all week. So I know for some of you online, we cover this a lot, but I think it's pretty important. So I look at 12 leads, pretty simple. They're either too fast, too slow, or okay-ish. Too fast, I still like American Heart. I think you go wide or narrow, regular or irregular, and follow that pathway. That's pretty reasonable. Too slow, 3 things cause you to get too slow, get bradycardic, and that's drugs, electrolytes, or ischemia. Now, I know what you're thinking. A lot of things can make you get bradycardic, but those things you pick up on your primary exam, right? So the dude that's shot in the belly and his heart rate's 140, he's agitated, and route to the hospital, his heart rate goes to 90 to 70 to 40. What's going on with him, right? He's dying, right? Hypovolemia. The 6-month-old that's blue with bradycardic, what's their problem? Yeah, it's hypoxia, right? But things you can't pick up on your primary exam is drugs, electrolytes, or ischemia. And we'll talk about some of those. And then the third thing is okay-ish. So that's the rates between 50 and 140. Those are the ones that will bite you. It's a STEMI, it's not a STEMI. Maybe it's a drug overdose, TCAs. Maybe there's some infection, things of that nature. And then you can also use AVR to kind of give you some idea of what's going on with some people. So too fast, too slow, or okay-ish. An EKG is a screening tool in a symptomatic patient. It does not have to be fancy. You need to have a way to calculate rate. Do not trust the machine. So if you print one of these things out, I don't look at the numbers. I don't look at the readout. I use the box method. So I say one box is 300, then 150, then 100, then 75. Then I start thinking about fishing or having a drink, and I forget about things. And when I wake up, I know I'm way too slow, right? There are a lot of ways to calculate this, but have a way that works for you. You got to know intervals. Remember in medic school, we learned that the PR interval. What's a long PR interval mean? Anybody know? Anybody care? First 3 heart block. What do you do different for a first 3 heart block? Nothing. That doesn't matter, right? But a prolonged PR in the setting of a wide QRS is concerning for hyperkalemia. So we got to understand intervals. QRS, if you don't know what a wide QRS is, you're not going to recognize VTAC. And you may think, but nobody's going to do that. I got plenty of charts I can show you where people have not recognized VTAC. All right. QT, what's the problem with a long QT interval? What can that cause? Torsades, right. So people die from torsades. So those are things you got to recognize, okay? We don't have to be cardiologists. We don't have to be fancy. We don't talk about vectors, but we got to recognize things that kill people because we can intervene and make a difference. And that's why most of us got in this job. So this one, too fast, too slow, or okay? The rate. Nobody's going to talk now because we're online. Yeah, the rate's reasonable, right? So it says 73, but we don't look at that, right? So I'm going to do the box method, 300, 150, 100, 75. So yeah, 70 to 80. Does it really matter? No, that's reasonable. The next thing I'm going to do is I'm going to look at injury patterns. So pattern recognition, I'm going to look at leads 1, AVL, and 5 and 6. Those are my lateral leads, and I'm going to look for ST elevation. If I got elevation in any two of those, it's a STEMI. Diagnosis is made. I'm on the phone, moving toward a hospital that can lyse this person or get them to a cath lab. All right. Other states, pre-hospital providers are lysing patients. Oh, there's a big dog walking around. Ooh, makes me uncomfortable. So, but ST elevation in 2 leads is a STEMI, right? You can see depression, you can see changes that make you uncomfortable. The elevation in any 2 of these leads is a STEMI. Diagnosis made. Next place I look is lead 2, 3, and AVF. These are my inferior leads. I'm looking for the same thing, ST elevation, T-wave inversion, depression, but elevation in any 2 of these is a STEMI, right? Next thing I do is V1 through V4. These are your septal, 1 and 2, and anterior, which is 3 and 4. ST elevation there, 1 millimeter or bigger is concerning for a STEMI. You can also look for posterior infarcts as well. So T-wave inversion, ST depression there is a posterior infarct. Some people try to get fancy and try to do a posterior EKG if they see this. Switch the leads, put them on the patient's back. Yeah, you can do that once you get to the cath lab or cath center. This is enough information right here in a patient that has signs of ACS to get them to a cardiologist. I'm not going to waste time doing a posterior. This is a screening tool. I got a patient that's nauseous, diaphoretic, that's older or having chest pain with this EKG. This is a STEMI. I'm waking up cardiology, and they can say no, but we're going to say yes. And then the last place I look is lead AVR. And we were taught years ago that AVR is only really good to tell you if the leads are on correctly. So if the big deflection in 1 is up, the big deflection in AVR should be down. That means my leads are on right. In reality, elevation in lead AVR alone and depression anywhere else in an injury pattern is concerning for a STEMI. Okay, it's a STEMI equivalent. So sometimes older folks who get septic, hypotensive, tachycardic, dehydrated, you may see their EKG change in front of you. They go up in AVR and down laterally, all right? The problem with those guys is they have atherosclerosis, bad heart disease. We strain the heart out, okay? But that can still be a plaque or a clot. So elevation in AVR, depression anywhere else, inferiorly or laterally, is concerning for a STEMI equivalent. And we're going to talk to cardiology. I'd rather you wake somebody up and have them say no than somebody die on the wall at some hospital, right? The next thing I do after I do that is I go back and I look at my intervals. So you look at lead 2. I say, what's the PR? I look at my QRS and my QT, all right? If those are normal, I'd go one more time at injury patterns before I put that EKG down, because some days I'm way too tired and I forget things, right? Right. If this is abnormal, if this is a wide QRS, then I have to go over to lead V1, and I'm looking at left and right bundles. And for the first couple of years of EMS Challenge, we didn't talk about left and right bundles. Now we're pushing that pretty heavy. I think that should be a basic skill for entry-level paramedics and for anybody practicing is to reckon. So if I was looking at this EKG, I would say is it too fast, too slow, or okay-ish? I say the rate's okay-ish. I'm gonna look at injury patterns. I'm gonna look at 1, AVL, and lateral. It looks funky. That is a medical term, right? I got some lateral T-wave inversions, not a STEMI. 2, 3, and AVF looks abnormal, but not a STEMI. V1 through V4, I got elevation in V1, V2, makes me uncomfortable. I'm gonna go to AVR, hard to see with that line there, but it's opposite of 1. So I go back, I look at my intervals, my PR in lead 2 is reasonable, my QRS is wide, so I go to V1, and I got a downward deflection, and to keep it simple is a screening tool. This is a left bundle branch block. And now I know by some other criteria we can talk about called scarbosa that this EKG is probably okay, not a STEMI, all right? However, if the patient's sitting there diaphoretic, saying they can't breathe, hypotensive, having chest pain, I'm still concerned about them, right? But the EKG is a little bit reassuring because it's a left bundle without scarbosa. All right, so what causes a left bundle branch block? Anybody know? Anybody care at 9:10 in the morning? So anything that jacks up the left side of the heart, right? So if you think about the heart, it's got the conduction system through there. If this left side of the heart gets ischemic or it gets enlarged, it's going to delay that passive electricity. So you get that wide QRS complex bundle branch block. So chronic hypertension, cardiomyopathy, anything that makes the left side of the heart get big, okay? So left bundle branch block. There are a lot of textbooks, explanations, definitions of how to define a left bundle. I try to keep it simple. I'm from Mississippi originally, so you got to do that, right? Anybody from Mississippi? Good. 2 of us here. We made it through college. Good job, sir. So wide QRS, all right, and I'm looking at V1, a downward deflection. That is a left bundle by a screening tool, okay? If you want to use other ways to do that, more power to you, as long as you know what you're doing. And if you don't like my pathway of how I interpret EKGs, that's fine too, but you got to have a way that you can do it and do it the same way every time. Anybody here work 24-hour shifts? Anybody here work 48-hour shifts? I'm not going to go any farther because that's already too long. We all get tired, have the same way to look at these EKGs so you don't miss something and then somebody die in front of you. So left bundle, right? Scarbosa's criteria for left bundles. We recognize that the septal and anterior leads are going to be with some elevation just because of the way the vectors are. So you can use scarbosa. So concordant ST elevation anywhere is bad. T wave going the same direction as the QRS that's elevated is a STEMI, all right? The discord for posteriors, the concordance posteriorly is also bad. That is a STEMI. The gimme you get is in V1 through V4, right? The discord, QRS one direction, T wave the other direction, you get one big box now, not one little box. So you get a little bit of play there. So discordance is good, and there's scarbosa's criteria. Now there's modified scarbosa, there's calculators you can use. Feel free to look that stuff up and use that. But for me, this is what I remember, and this is enough to kind of screen the patient through so I recognize, are they sick or not sick? Do I need to see a cardiologist now, or do I have time to work them up a little bit more? Questions, comments, statements within reason? Sweet. So this is the one we looked at earlier, right? So we talked about, we have this lateral T-wave inversion, funky but not STEMI. We have elevation here, but we recognize that the QRS complex is wide, so we went to V1, downward deflection. I got discordance here, QRS going one direction, T-wave in the other. So I get one big box before I say STEMI, and I only got a little box. So this is a reassuring left bundle branch block, okay? Before 2013, if somebody came into the ER I was working and they had this EKG and had chest pain and I couldn't prove that they had an old left bundle, we called cardiology. We kind of backed away from that now. Now somebody can have a big ischemic event and get a brand new left bundle, but I can tell you they're not going to look good. They're going to be hypotensive. They're going to look like dirt, diaphoretic. They're going to look like near death with a left bundle. That's why in addition to the EKG, you look at your patient. All right, this one, too fast, too slow, or okay-ish. I say the rate's okay, right? So the machine says 95, but again, we don't look at that. If you calculate it, 300, 150, 100, around 100 or so, reasonable rate. Injury patterns, I'm gonna look 2, 3 and one AVL and lateral. It looks funky, but not a STEMI. I'm gonna look 2, 3 and AVF. You got some T-wave inversions. I'm gonna look back through V1 through V4, right? And I got that T-wave inversion, ST depression. So that makes you think in posterior infarct, right? AVR is reasonable. I go over to lead 2, periannual is good, QRS is wide. So if the QRS is wide, we go to V1, and now my big deflection is pointing up. So what is this? If it's not a left bundle, it's a right bundle. Yeah, I like it, right? Yeah, it's like right hole, wrong hole, right, with intubation. So this is a right bundle. You don't use scarbosa with a right bundle, but the reassuring thing with right bundles is that if you have a complete right bundle, this is normal. So this makes me feel better about the patient. It doesn't mean I'm not going to do a history and exam. I'm going to get my vital signs. If they're having chest pain, I'm still going to do my therapy for that. But I feel very reassured that with the right bundle and this is normal. This is probably not a posterior infarct. What causes a right bundle branch block? You got to think Mississippian. Anything that jacks up the right side of the heart, right? Yeah, so what can jack up the right side of the heart and make a right bundle branch block? What kind of people get these? So right-sided heart failure, maybe the guy's been smoking since 1972, he's got increased pulmonary pressure, he gets a right bundle. Maybe the guy with pulmonary hypertension, maybe it's the guy that's got left-sided heart failure, now they have right-sided heart failure. What's something acute, something that happens all of a sudden that can cause a right bundle branch block? Young female, history of smoking, she's been on a flight to Jamaica, her right leg is now swollen, she's got chest pain, she's hypoxic, got this EKG. What does she have? A PE. Yeah, you diagnosed it. You don't need a lab. You don't need a CT imaging. You got your diagnosis, right? High risk for somebody dying. You get them to the appropriate therapy. Cool. Again, lots of things to think about, lots of pathways, mnemonics you can use to memorize right bundles. Find one that works for you so that you don't miss this at 2 o'clock in the morning. Questions, comments, statements? Sweet. This is just a diagram that kind of shows injury patterns and what you can look for. You can kind of overlay this over your EKG, gives you an idea. Lateral infarcts are 1 AVL and 5 and 6. The right coronary inferior is RCA. LAD is a big portion of the heart. If you're up in AVR and depressed anywhere else, that means that either the right or left main coronary is really occluded. That's a bad sign. A lot of times we don't see this. This is the guy that was having chest pain, and when we show up, they're doing CPR, right? Because a large portion of the heart is really in bad shape. I show this every time, so if you've seen this before, you're probably rolling your eyes, but it proves a point. What's wrong with this monitor right here? What cannot be real with that? Anybody see anything? Anybody even care? Anybody hungover? Yeah. Yeah, the blood pressure, you really can't have that, right? It's kind of silly, all right? But I say that to prove a point that you cannot trust the machine on the 12 leads. The reps, please vendors, close your ears. The reps will tell you the machines do a great job. I'll say no, that we do a great job. The machine will fail you every time. Learn to read your 12 leads or your patients will suffer before that. And this is my inappropriate humor. We learned we cannot trust machines in 1987. We should have remembered. And for the older folks in the crowd, we also had a hint in 1981 that we can't trust the machines. What about this one? Too fast, too slow, or okay-ish? The rate. The rate looks fairly reasonable. So I got 300, 150, 100, 75, 60, so a little bit slow. So around 50 to 60 is what I calculate. I'm gonna look at injury patterns, 1, AVL and lateral, nothing. 2, 3 in AVF, V1 through V4, AVR. I go back, look at my intervals, right? A little bit wide QRS, not real wide, but the big deflection is going up. So maybe it's a right bundle branch block. So is that a STEMI or no STEMI? You can comment. Nobody can see your face. They just see my face. That's bad for them online. Yes, no, maybe. Nobody comments. Yeah, I'm going to call it a STEMI. What's the machine say? Machine says nothing, right? If this is a right bundle, which way should this be going? That should be going down, right? So the machine's going to say right bundle. I would argue this is, yeah, call it a right bundle. But either way, that's a STEMI, right? And if we miss this, bypass a hospital that can lyse them or get them to the cath lab, or is anybody seeing wall time, parking, whatever you want to call it? I know it's not happening. So good, good, good. Y'all are doing great, better than Birmingham. So you sit on the wall for 45 minutes with this patient and nobody looks at this EKG but you, and then he gets triaged and has an EKG. What's going to happen? High risk for decomposition, right? Decomposition, that's when you did. Yeah, sorry. All right, so again, very important that you as a medic know how to read a 12 lead. I know some of us here did not get that training in school. I get it, but it's time to get it. Okay. There are a lot of resources out there. If you like my method, use this. If you don't, you're not going to bug me. Wave Maven is a great resource online. Life in the Fast Lane is another blog. There's a doc out of Atlanta that does a great job. I can't pronounce his name or I'd say it. But a lot of resources. Just if you're responsible for doing a 12 lead and reading it, know how to read it. Do not trust the machine. All right, let's talk about some cases. So 34-year-old male driving to work, had chest pain all morning, but kind of dizzy, about to pass out. So calls 911, pulls the car over, gets out of the car. He's sitting on the side of the road. Smells of alcohol, got track marks, a lot of tattoos. I think that's a famous singer, but I'm not sure. So what are you going to do for this guy? Going to get back in the car and go home? He's 34. Yeah, so he gets the same kind of care that everybody gets, right? So you're going to do your primary exam, your ABCs. This is just the first case we're going to do today. You'll catch that later, first case. So guy may have syncopized, right? Syncope, pre-syncope. So you get ABC exam, gets an AccuCheck, you're doing an appropriate history on this guy, then obviously you can get an EKG on him. And I showed this last time, the time before at Oxford when we did our class, but there's some more information that came in. I wanted to kind of re-hit this one. So too fast, too slow, or okay. And if you say okay, you need to go back and take a nap somewhere. Yeah, it's not too fast, and I would argue it's too slow. I'm not really sure how to count this rate. The monitor is going to tell you it's in the 50s. I tell you, when you reach down and you grab his pulse, it's going to be about 24. That's probably an escape beat. It may not be perfusing. So he's breathing fast. He's diaphoretic. Sats are 96. Blood pressure is low. Glucose is great for Alabama, right? That's almost hypoglycemia, all right? All right. So when you have somebody that's too slow, what three things do you think about? We mentioned electrolytes, drugs. By drugs, I mean beta blockers, calcium channel blockers. Either they took too many trying to kill themselves, or they take their normal amount and now their kidneys aren't working, they can't clear it, right? Or the third thing could be ischemia. And what do y'all think about that? That looks like ischemia to me. That makes me get sweaty and diaphoretic. I'm popping the Lamodal as I'm taking care of this dude, right? So super sick. So what are we going to do for this guy? Nobody's going to talk to me. Great. It's like talking to my family. All right. So I would argue that he is too slow. So three things we think about: drugs, electrolytes, or ischemia. I'm going to argue it's ischemia looking at that 12 lead. All right. So he's symptomatic, all right? So I got to fix that heart rate. Remember, the heart gets its blood supply from each beat. If he's only perfusing half of those beats, the heart's even more hypoxic. So I'm going to sit him up, get him against the car. I'm going to throw an IV on him. I'm going to throw some oxygen on him. And I know that people don't like O2 if their sats are fine, but I would call it pre-oxygenation before he codes, all right? I'm going to sit him up, start a line, and I'm going to try to increase that heart rate, okay? So quick and easy things. Somebody's hanging a bag of fluid and pushing that in. We're squeezing that. All right. Somebody's starting a second line. Maybe we're throwing the pads on the guy. And there's a drug we can use that a lot of folks don't like anymore because we got fancier drugs. But there's an old school drug that works pretty good to fix some of this. What drug would that be? Atropine. Praise God. Thank you for saying atropine. Good. Not adenosine, right? Yeah. No. You laugh, I laugh. I can show you the chart. So guy gets one of atropine, right? So one of atropine, old school drug. A lot of folks say it doesn't do a lot of good. Yeah, but there's no risk to it. So one of atropine, if I increase his heart rate, I can high five my partner and know that he's getting better, right? So I got to fix his rate or he's going to die. So I got fluids cooking. I got the atropine. Obviously, we're throwing the pads on the guy in case we have to pace him, all right? So this is with the atropine. You can see where it kicks in, right? So now our rate's improving. So we fixed one problem. temporarily. We've increased his rate, so we know that his perfusion is going to get better. So I gave atropine, I gave fluids. But now we also got to think about what else is going on. Dude's still having a STEMI, we got to manage that, right? So there are a lot of mnemonics out there. There's Mona, there's Fona. Some people talk about Kona using ketamine. I'm not a big fan of that with cardiac events. All right. What's the first drug we want to give this guy after we give the fluids and atropine? What's the most important drug? Aspirin. Yeah, so aspirin is a blood thinner, right? It kind of jacks up the platelets. I'll put those slides. Yeah. So if you have a blood clot in your body, right, you give someone an aspirin, it's not going to make that clot go away. What it's going to do is make it where that clot can't get bigger. If you think about platelets, they have receptors that look like little plungers on it. Again, that's the Mississippi interpretation, right? And aspirin will jack up those plungers, those connectors, so you can't make a clot any bigger. So we're not fixing the clot he's got, we're making it not get any bigger, right? He obviously has some perfusion because he's not dead. We want it to stay that way. So aspirin is super important. Is there anybody that you would not give aspirin to that's having a STEMI? So I hear somebody that had bleeding, I heard allergic. Yeah, so my argument would be risk to benefit. They get an aspirin with a STEMI unless they tell you that every time they take an aspirin, their face swells up and they get their neck cut. Otherwise, they get an aspirin. What if he took an aspirin like 40 minutes before he left for work? I don't believe him. 2 aspirins is not going to kill you, but not having one potentially could harm you. I've had people call aspirins Lortabs, Norcos, Advil, crack, whatever they got. I don't trust them. If you give a patient an aspirin, I trust you. You know what you're doing, right? If a patient gives themselves an aspirin, I smile, great. Yeah, give them one more aspirin. Risk to benefit, they need that aspirin, right? There are other medicines we can give in the hospital that work pretty well as well, but in the field, aspirin is what we got. So aspirin basically jacks up, if it was a Lego, it would take it where you can't connect these, so the clot does not get bigger. And I forgot the story behind why I put a fish up there, but it's a cool looking fish. The other thing to think about is the things that kill you in a STEMI in the first couple of hours is VTAC, VFib, or complete heart block. So these guys get the pads. They also get oxygen. And I know American Heart says that you don't give people O2 in cardiac events if they're not hypoxic. I would argue someone breathing 24 times a minute is still having difficulty breathing. I would also argue that in the state of the world we live in, where we don't have many responders, throwing somebody on a couple liters of nasal cannula and calling it pre-oxygenation is reasonable. That way, if they go into cardiac arrest en route to the hospital, you're not fumbling around for a non-rebreather or other things. You just put your cigarette out, reach over, crank the O2 up to 15 liters. They have passive O2. You have time to pull over, get help in the back, but you're oxygenating them. There's pretty good evidence that O2 long-term in cardiac or strokes or people that are not hypoxic is bad, but that is long-term. It's not the first 4 hours. And you can actually go to bars in Denver and get oxygen. You know, if you go to a bar, it's got to be good for you. So, all right. We talk about pads. You can't put the pads on every patient with chest pain, you'll go broke. But pads on patients with STEMIs make a difference. This was a BFR case last year, I think, or the year before. Big STEMI, they had the pads on. The guy goes into VFib in the back of the truck. They just charge, fire it off. He comes rolling into the hospital screaming and cussing, but hey, he's alive, right? And that's much better than starting CPR, pulling over, giving drugs, then shocking. They were prepared, they intervened, makes a difference. All right, back to that dude we were talking about. So this is his EKG, increased his heart rate, he feels better, blood pressure's like in the 140s, still having some chest pain, still a little diaphoretic, but this is his repeat 12 lead after fluids and atropine. Too fast, too slow, or okay? I'd say it's okay. I'd also say it's a whole lot better, right? I'm gonna look injury patterns. I'm gonna look at 1, AVL, 5 and 6, 2, 3 and AVF, V1 through V4, AVR. I'm gonna look intervals because I did this the same way every time so that when I'm tired or overconfident, I don't miss things. So is that a STEMI or no STEMI? Nobody's going to talk to me. This is wonderful. I'll say it's not a STEMI. I don't see anything super scary, right? I would say his previous EKG was scary as dirt, right? So we can pull over, tell this guy he's good to go home, pull his IV, see his doctor tomorrow. No. He still goes to a STEMI center. He still goes to a cath lab. We need to show that EKG previous that we got to the cardiologist, to the ER doctor. That will make anyone uncomfortable, right? Cool. So what probably happened between the atropine, the fluids, and this EKG? Anybody know what could have happened? Essential oils, they kind of rubbed his feet a little bit. That's great stuff, right? No, actually the medic noticed the guy's blood pressure was higher and still having chest pain, so he popped a nitro right after that atropine. I probably would not have done that. I'm not sure that I have the courage to give somebody 20-ish, right? But medicine is interesting. You kind of practice it, right? Dude's heart rate had improved at that time. His blood pressure has got better. And I would argue that that nitro actually helped the guy at this point, right? About 5 or 6 minutes down the road as they pulled him into the hospital, they repeated EKG because that's what you do, serial EKGs. There's no risk to the patient. And if your med control doc can charge for them, they like it when you do more, right? That was a joke. We don't charge for that. And this is the repeat EKG 5-8 minutes after the nitro. And what do y'all say there? STEMI or no STEMI? STEMI, yeah. Once again, I'm popping the modal because I'm concerned this dude's fixing to arrest. So I know we talked about this one some last month, but this was pretty interesting when I got more of the details. Very challenging, and I would argue a good call by the medic who did more than just follow check boxes. He actually kind of thought through the process, did critical thinking, made a good call on somebody who was sitting on the side of the road. Save this guy's life. So when you think about care for STEMIs, we talked about Mona, Fona, the aspirin, nitro. We talked about oxygen. Morphine will lower your blood pressure if they're hypertensive. It's a pretty decent drug. It doesn't really help the heart, but it makes them not care they're hurting. Fentanyl's good, kind of helps, maybe it helps the anxiety and their pain. I'm not a big ketamine fan. And then I started using this mnemonic here, SITAIVNRTLPOM. It's easy to remember. And we have stickers and tattoos you can put on if you need those. But it's suspect that ACS is going on. You suspect it by just chest pain, apheresis, history, old age. I don't feel good. I passed out. We have a tool that can pick up something that we can fix. It doesn't cost anything. It doesn't hurt people. Use it. Get a 12 lead. So suspect, identify it, know how to read them. If you recognize a STEMI, treat it, and then start moving toward the hospital. Treat it almost like a trauma because we can do things now. We can lyse these people or give them the cath lab. And then the AIVNRTLPOM, maybe it stands for aspirin. That's easy. Aspirin IV, nitro, ride to lightning pads. That's the defib pads. Oxygen and morphine. And again, you don't have to use my mnemonics. That's fine. But have a way to manage your patients and know what you're doing and critically think. And if you don't use mnemonics, even better. That means you can think through the process and know how to take care of people. All right. We call them patients, but they're people that we live near. I know everybody's seen this form. This is a state required form in the protocol manual for our STEMIs. We have them for strokes as well. It's a lytic checklist. I would argue that if you're not doing these, you should at least ask the questions and pass this information on to the hospital. If this dude went into cardiac arrest and we didn't have this information, I have to make a decision to give him a lytic, all right, immediately. And if he had just had a stroke or had a brain aneurysm, I can't give him a lytic. I will kill him. There's no reason to do that, right? We'll do other things to try to get him back. So these questions are important. This should be given off to the physician at the ER. Nothing against the nurses, but the decision to lyse somebody will be on that doc. So find that physician and let them know you did this checklist. If you write it on a glove, so be it. Tell the doc, and then you can ask for this form, or if they want the form, fill it out. But you got to get this information, all right, on STEMIs and strokes. We won't go into detail. Remember, a lytic is not like aspirin. Aspirin makes the clot not get bigger. If I give somebody TPA for a stroke or a heart attack or TNK, it's going to take that clot and break it open. But any clot in their body they have is going to break open. If they just had spinal surgery, they're going to bleed there. If they just had gastric surgery, they're going to bleed there. Car wreck and had a STEMI and have an open femur, and I give them this drug, they're going to bleed where that femur is. All right. Retivase. Anybody know what Retivase is? Anybody using Retivase? Retivase is a lytic you can use pre-hospital. It's a 2-dose drug. You're on scene, dude's having a chest pain, you get a EKG, it's a STEMI. You go through this checklist. You recognize he has no high risk factors for contraindications to give an lytic. You give the Retivase. You watch that EKG as you move to the hospital. If he gets better and fixed, great. He goes to a cath lab in a couple hours. If he doesn't, he gets 10 more Retivase when he gets to the hospital, and then he goes to the cath lab. Those are things that are coming to pre-hospital. But to get to this point, you got to know how to do a 12 lead. This is that guy's cath. Not the greatest pictures, but it's the best I can do. One of the benefits of working at a place that is a heart attack center, I think that's the fancy medical phrase for it, is they need our data. They need to look at our time to patient contact in 12 leads. And so that they need our data, we get feedback. So that's that 34-year-old, got a stent. He's got this device. This is an Impella. Again, the Mississippi definition is this is like a fan that's put in there that blows the blood back into the heart to increase the perfusion pressure of the coronary arteries. It's sort of like a balloon pump, okay? It makes the recovery time better. And this is a young guy, 34. He's probably got numerous years of life. So a big save, big save. All right, let's talk about some liver issues since we're at the beach and I saw people last night. Liver failure is bad. Probably 9th leading cause of death in the U.S. for the past 10 years straight, or at least in the top 10. About acute issues for it, we don't see this a lot. Tunnel poisoning, certain drugs, some mushrooms, trauma. The big thing is alcohol, hepatitis. NASH is big. That's the fatty liver. We as Americans who are diabetic or pre-diabetic are moving toward that. But the liver has a lot of issues. Remember, the liver gets its blood supply from 2 sources. It gets it from the aorta, and it also gets blood supply from the colon, the stomach, and the intestine, right? Anything in the gut, anything you eat goes into your body. The blood from that area goes back to the liver. It filters the proteins, the alcohol, the hush puppies, and the liver uses that for certain things. When the blood comes back through the portal vein into the liver, it goes through cells that takes those nutrients. It makes proteins to clot the blood, to fight infection, to store glucose, to make things. It makes proteins that go back into the bile so you can digest more things. But if you're eating bad things, high-fat foods, drinking alcohol, that kind of plugs these pores, and it makes the liver not work. Then this blood gets backed up, and you get portal hypertension. You get ascites, cirrhosis, all kind of issues long-term for this. Nope, semi-inappropriate humor. I try to make it all semi-clean today, too. Cirrhosis is when the liver gets nice and hard, and it doesn't function. Alcohol effects on the body. Obviously, you can get some amnesia. You get some issues with memory, right? It talks about you get relax of the pharynx. You have people that have esophageal issues. You can get obstructive sleep apnea. In reality, it's probably more based upon the decisions you make when you drink is why you get food stuck in your throat, but it can cause some issues there. You can get some early dementia. You get cerebral atrophy. You can get some muscle wasting. You can get this nystagmus, and that's what you see down the side of the road by law enforcement. Down here, a few streets down, and then you get some muscle wasting. Alcohol leads to increased psych issues. Anybody here ever had a law enforcement tell you the patient, you go to jail or you go to the ER? Anybody ever heard that phrase? Or is it just me that hears it sometimes? Right, yeah. So we see a lot of alcohol-related ER psychiatric issues. You get more malignancy. Alcohol changes things. You get malignancy in the liver. You get oral, esophageal, other issues. In low quantities, alcohol is good. You get euphoria. You can do anything you want to. You relax. Increases your HDL, which decreases risk of heart attacks. But that's in low quantities. And again, looking at last night, I don't think there were low quantities. So, Alcohol increases cortisol. It causes trouble with glucose metabolism. It causes hematological problems. Folks who drink alcohol have liver disease or high risk for bleeding. They're almost like they're taking Coumadin or anticoagulants. They bleed pretty easily, so they're high risk for bad outcomes from trauma. It can cause some cardiac events. Holiday heart was an old phrase, but basically alcohol can cause AFib. You see it more commonly in young folks who go out and binge drink on the weekend, like when LSU beats Alabama, they get drunk and they get AFib. Too soon, wasn't it? Sorry. You can get some increased heart disease. You get some cardiomyopathy. Remember, alcohol is really a CNS depressant. It pushes the CNS system down. So the body's response to that is to increase blood pressure, increase heart rate, which leads to other problems. You get gastritis, pancreatitis, lots of issues there. I'm not sure what that one was supposed to be for. Back to Denver. And then you get some reproductive issues, which I won't mention either for alcohol. So in short, alcohol can kill the liver, cause malnutrition, anemia, increased risk of bleeding. They bruise easily, cerebral atrophy, and all kind of issues. Semi-inappropriate humor. In the next case, are y'all catching on with the cases? The beer gets worse every time. All right, I thought it was funny. So altered mental status. This is Earl, frequent flyer to the ER. He moans to painful stimulus. He's got contusions, abrasions to his scalp. His belly is distended, heart rate's in the 130s. He's hypotensive. He's breathing fast, a little bit hypoxic. What does he get? He gets the ABCs, right? AccuCheck, sit him upright. Think about maybe some oxygenation for the guy. But we just don't assume he's drunk, right? So you think about alcohol causes cerebral atrophy. That means the brain shrinks. When the brain shrinks, the vessels that run through the dura are venous vessels. They start pulling and tugging. So these guys, even small falls will make these vessels tear and lead to bleeding. If they weren't an alcoholic, they may not bleed so freely, but he's an alcoholic and his blood doesn't clot. So now this bleeding gets worse and he gets a subdural hematoma, blood in the brain, and that kills people. So you never assume somebody's drunk. Folks that are intoxicated and injured get a complete workup, or you're going to miss something one day. I know you see on the news and there are jokes about the guy who survived the car wreck because he was drunk. And yeah, he survived it that night. He went home, he didn't know he was hurt. But a lot of times the next day we see him in the ER or the coroner sees him. So these guys get a big workup. So the dura is an organic saran wrap that kind of protects the brain. You get bleeding. This is the CAT scan. White on a CT means blood, which is bad. 3 types of head bleeds: the epidural, which is arterial, the subdural, which is under this dura, usually venous, and then you got the hemorrhagic strokes. What is this one? If white is blood, the other one's subdural. What is this? This is nice and pretty. This is an epidural. This is somebody that fell, got knocked out, woke up, and then about 45 minutes later started seizing. This person needed to be in the OR 45 minutes ago. But alcoholics are high risk for head bleeds. All right, next case. We're getting better, right? Old Milwaukee. This guy was altered. You're called to the scene at a restaurant one morning. He's unresponsive. Bradycardic. In the 80s, 116 for first responders. ALS shows up. What are your concerns for this dude? Airway. Yeah, so how are you going to manage this guy's airway? What are you going to do for this guy? Yeah, we're going to sit him up and not lay him flat back on the stretcher, right? So sit him up, lean him against the wall, the table, lean him against your buddy, the newest guy, so he gets the vomit on him, right? You're going to maybe do a nasal trumpet that works great. There's no gag reflex there. Nasal trumpet, high flow O2, suction the airway, assist ventilations, determine does he need to be orally intubated or can you nasally intubate him, right? He's not one you just roll over, flatten his back, suction him out and try to bag him, because that's not going to work for this guy. Aspiration is bad. Chunks of shrimp and hush puppies in your lung is bad. It definitely needs lots of oxygen and airway management. Then you think about other things that can cause him to be altered as well. That got your attention, didn't it? Yeah. Now people are looking at me. Good. So Roll him over, elevate the head of the bed, O2, adjuncts, nasal trumpets are great. Ventilate this guy and look for other causes, right? Look for signs of trauma. Maybe he was beat up as well. Maybe he was doing opioids, other reasons. Critically ill people, you expose them, look for life threats, and you be aggressive in your care with that guy. Yeah, I can't look at that much either. This is the x-ray. So if you look at the lungs, the nice black of the lungs, this is all food. That's why you get hypoxic when you aspirate in that right middle lobe. It takes more oxygen to oxygenate you. Big risk for these folks. Sometimes we see these guys come in and they got both lungs full of food, really can't ventilate them. Things that we could do from the hospitals. A lot of times we start antibiotics. Sometimes need it, sometimes you don't. What they really need is just high flow oxygen. If we can't oxygenate and ventilate them and they're young, at UAB we can do some ECMO. We bypass the heart and the lung, and then we just give them a couple of days for the lungs to heal up and start ventilating. But people die from this all the time. Just Google some rock stars and you'll find a couple. All right. One more QR if you need us today. Last case. And this we get to Listerine. That stuff's really bad to drink though. 53-year-old male drinking since David left Van Halen. Anybody know what year that was for bonus points? I'll give you a t-shirt if you tell me what year. Painful. It got worse when David Lee Roth came back. I understand that. Dude says he's going to quit cold turkey. He's altered, confused. Family said he may have seized. Heart rate's 130. Blood pressure is 225 over something, the first responder says. So what's going on with this guy? What now? DTs. Yeah, he's withdrawing. Alcohol will kill you if you quit it cold. You can stop any other drug out there and feel like dirt, like you're going to die. But if you quit alcohol without help, you can die. Remember, we talked about what it does. The CNS depressant, it pushes down the CNS system, so the body's response is to increase heart rate and blood pressure. You quit drinking, now your blood pressure goes out of the roof, heart rate goes up, you get increased CNS stimulation, you seize, you have strokes, you have heart attacks, you die. How do we treat alcohol withdrawal? What do we give them? We can give them in the hospital, benzos, right? Or you can give them a beer, alcohol. All right. Yeah. Some hospitals I work at, you can write an order, 12-ounce beer, TID. You can't pick the beer, but you can give them the beer. So CNS depressant, you stop that, everything goes haywire, people die from that. So management on scene for this guy is going to be ABCs, look for life threats, quick 12 lead, O2, make sure we're covering the airway on this gentleman, check a glucose, and then you call in med control, or you're going to assume and you give him some Versed or Valium or Ativan, whatever you carry, and that's going to fix you. Last slide, and we'll call it a day. I like these pictures for a couple of reasons. This is at Five Below. Have y'all seen these? So you notice that the doctor's arms are bigger than the EMT arms. Just want y'all to recognize that. Okay. Oh my God. Yes, it is orthopedic surgeon. It's not an ER doctor. That's for sure. All right. But I got 3 rules that I try to live by. And I know if you've heard me say this, you're probably sick of it. But one is I don't want to kill people. Kind of sounds stupid, but the things that you do in the field, the medicines, the procedures, the things you can do can kill someone if you do it to the wrong patient. It can save them if you do it to the right one, right? And the way you don't kill people is you practice, you train every day, you don't get complacent. I try and help people if I can. There's some things I can't fix. If I recognize somebody has a subdural, I can't fix that. I call a neurosurgeon. If I take you to the OR to fix your head injury, you will die. Nothing, no doubt about it, right? Just like you guys, you can't fix that either, but you can recognize the risk for it. You can recognize that STEMI and get them to the right place. And then your conscience is clear. And the third thing is I want to go home with that clear conscience. And I do that by training. You're going to make mistakes. You're going to do everything right, and people are still going to die. But you can go home with a clear conscience if you train, you practice, and you're prepared. Okay. This last picture, calling this dude here a day laborer. Is crazy. He's not a day laborer, is he? That's like calling EMS providers healthcare providers. You do the same job, but you do it in a different environment. And one of the things that we as healthcare as a whole, physicians have done is we're not doing our part. So again, part of the purpose of EMS Challenge is to get more physicians, hospitals, healthcare as a whole to support you guys to take care of our patients. And the last slide is to let you know you can still drink some. I wasn't chastising you, but just be careful with it, okay? Questions, comments, or statements within reason. We got a couple of minute break. Any questions on the chat box, Chief? No questions. That makes me really uncomfortable. So if you need Con Ed here or online, you can do this. If you don't need Con Ed, please still scan this so we know who we're getting in touch with. We need feedback. We're doing good things. Let us know if we're doing things not so good. Let us know too so that we can change that. We're going to take a 10-minute break and then we'll come back with Dr. Brown. Unless y'all have questions, and I know you don't because nobody's even making eye contact. Yes, no, maybe. All right. Thank y'all.
So I'm Julie Brown. I am an ER doc at UAB, but I did an EMS fellowship last year. Today we're going to talk about cyanide, which is CN, and then carbon monoxide, which is CO. And they can be the silent killers on the fire scene, or they're also known as the toxic twins. All right. So EMS providers really frequently initiate care for critical patients in risky environments. Y'all know that. And gas and fire-related calls can really be complex and risky to not only patients, but also to the providers. And so we need to be able to recognize if a patient could have an inhalational injury from smoke exposure. So carbon monoxide and cyanide are colorless, odorless, metabolic poisons that can cause patients to lose consciousness very rapidly, but also can result in cardiovascular collapse. So think that patient that was in a fire that has no obvious burns, but they're in cardiac arrest. So think it might be carbon monoxide or cyanide. So it's really important that we can quickly identify if these patients are at risk so that we can give them life-saving treatments, or if a provider is exposed to these things so that we can treat them. All right, so these are our objectives, but this is the outline of what we're going to go over. So we're going to talk about carbon monoxide first, and then we'll talk about cyanide. We're talking about what is it, sources of exposure, the pathophysiology, signs and symptoms, the treatment, and then any kind of special considerations like pediatrics or pregnant patients. All right, so we're going to talk about carbon monoxide first. So what is carbon monoxide? So it's a colorless, odorless gas that's made from the incomplete combustion of fuels. And about 50,000 people annually in the US are actually exposed or poisoned by carbon monoxide. And the majority of those are related to fire smoke inhalation. And about 1% to 3% of the people that are exposed actually die. And that's about 1,200 to 1,300 people per year in the US. And 2/3 of those are actually intentional. So for those unintentional poisonings, it's more common, obviously, in the winter months or a cold climate. So not likely to be Alabama right now. And then more common after a power outage. So if there's a bad storm, a snowstorm, and people are using gas power generators in their garage, right next to their house, inside their house, you might be more likely to see this. So what are some sources of exposure? So we think obviously smoke inhalation from fires, any kind of poorly functioning heating system, so a kerosene heater, a faulty furnace, improperly vented fuel burning devices, so those gasoline generators, camping stoves can cause this, and then motor vehicles that are operated in poorly ventilated areas. So these might be something you might not think about. So ice rinks, if you have a gas-powered vehicle in a ice rink, if their tailpipe is covered by something, by snow, or accidentally by some sort of cloth. motorboat exhausts, and then underground electrical cable fires. So the carbon monoxide can actually sink into surrounding buildings and homes. All right, so how does carbon monoxide work? So it has three different mechanisms. The predominant one is impaired oxygen delivery, which we'll talk about, and then impaired oxygen utilization. And then, I'm sorry, you can't see the yellow very well, but it can also generate reactive oxygen species. So normally you have, so in a hemoglobin molecule that's in a red blood cell, you have this, so you have these four, you see the yellow, those are iron molecules that are in the hemoglobin. So typically 4 oxygen molecules will bind to those iron molecules in the hemoglobin, and then it gets carried to peripheral tissues. The carbon monoxide will preferentially bind to those iron molecules with 240 times the affinity of oxygen. And if carbon monoxide binds to it, it's actually going to decrease the ability of the hemoglobin to release oxygen to the peripheral tissues. And so this is a better example. So normally, the picture on the left, you have a high oxygen environment, so think the lungs. You have the hemoglobin molecule with 4 oxygens bound to it. Then it gets to the peripheral tissues and releases all that oxygen. But if you have carbon monoxide, which is the black molecules in the environment, it'll preferentially bind to the hemoglobin. And then when it gets to the peripheral tissues, it won't allow the oxygen to be released. So carbon monoxide can also cause impaired oxygen utilization. So the predominant mechanism is the impaired delivery, but then about 10 to 15% of carbon monoxide is bound to molecules that are not hemoglobin. And those can actually go into the mitochondria, which is getting a little into the weeds, but the mitochondria is like the workhouse for the cell, so it generates all the ATP or the energy. And the carbon monoxide can get into those mitochondria and cause them to decrease energy production. And it can also act like cyanide, which we'll talk about later. And then carbon monoxide can generate reactive oxygen species. The important thing about this is that it's the thought that this mechanism causes the delayed neurologic sequelae, which we'll talk about. So what are some signs and symptoms that we should be looking for? So 90% of patients are actually going to present with a headache. About 80% will present with dizziness. About 50 to 60 will present with generalized weakness, nausea, and then some patients will present with chest pain, confusion, loss of consciousness, and then blurred vision. So what do we look for on exam? So if a patient has just mild to moderate toxicity, oh, I'm sorry, y'all. Whoa. I'm just getting a little preview. So mild to moderate toxicity, patients might present with altered mental status. They might be a little tachycardic, a little tachypnic. But if they have severe toxicity, these patients may present with a seizure, with syncope. They might be in a coma. If you're in a hospital setting, they might have a profound lactic acidosis. They can present with myocardial ischemia. So these patients might have chest pain. You get an EKG, it actually might show some ischemic changes. So they might look like they're having a STEMI. They can present with ventricular arrhythmias or pulmonary edema. And then there's this syndrome of delayed neurologic sequelae, which occurs in about 15 to 40% of patients that have a significant exposure. Typically occurs within 20 days after patients actually seem to have recovered, but it can occur anywhere from 3 to 240 days. And this presents with cognitive changes, personality changes, focal deficit, movement disorders. So they might look like they have Parkinson's, and it can persist for a year or longer. The mechanism of this isn't well understood, but it's thought that it has to do with reactive oxygen species. So when should we think about carbon monoxide poisoning? So if your patient is a victim of a fire, they seem altered, but they don't really have any burns, think about carbon monoxide poisoning. Or they can have burns and they're altered and they're just not breathing well. Think about it in patients that have flu-like symptoms, especially in a cold climate, if other people in the house are sick with similar symptoms. I know that's hard right now because the flu has taken over Alabama, but something to consider. Think about it, patients that have unexplained altered mental status, or if they have a lactic acidosis. So we diagnose this by a patient that has a known or a suspected exposure. And then in the hospital, we can check their carboxyhemoglobin level, which is the level of carbon monoxide bound to hemoglobin. And non-smokers can have up to 3% of this at baseline, and smokers can have up to 10%, and that's normal. And then if you give hydroxycobalamin, which we'll talk about at the end of the lecture, which is the antidote for cyanide, it can actually interfere with this measurement, and so it can be falsely low or high. So how do we manage these patients? Obviously, first and foremost, we want to get them out of whatever the source of the carbon monoxide poisoning is, because it's dangerous to them and it's dangerous to the provider. We want to focus on ABCs. So if they need an airway, take it, give them fluids, and then we need to give them high flow oxygen. So carbon monoxide is predominantly eliminated through the lungs. So if you give them high flow oxygen, so I'm talking a non-rebreather, 15 liters, it will decrease the half-life of the carbon monoxide because it competitively binds with hemoglobin instead of the carbon monoxide. So it can decrease that half-life from 250 to 320 minutes to 90 minutes. So even if, like, you obviously aren't checking carboxyhemoglobin levels in the field, but if you suspect that they could have carbon monoxide poisoning, just put them on a non-rebreather. They're not going to appear to be hypoxic. Their oxygen saturation might be fine, but just put them on a non-rebreather and just let the team know when you get to the hospital. All right. So another treatment that we can do in the hospital is hyperbarics. Has anyone ever heard of hyperbarics? Yeah, okay. So the goal of it is to reverse the acute effects of carbon monoxide poisoning and also to kind of try to prevent those delayed effects, the delayed neurologic sequelae. The best benefit occurs if you get hyperbarics within 6 hours, but you can see some benefit if the treatment is delayed, but it's really not proven to work after 24 hours. And so in a hospital, when do we choose to do this? So we have at UAB, we have hyperbaric teams. So they're the hyperbaric specialist, but this is generally what they go by. So if somebody's carboxyhemoglobin is greater than 25%, we'll consider hyperbarics. If they're pregnant and it's greater than 15%, we consider this. If they lost consciousness at any point, they can get hyperbarics. Or if they have severe metabolic acidosis or evidence of end organ ischemia. So if they have EKG changes, if their troponin is elevated, if they're in respiratory failure, if they look like they're having a stroke, or if they're altered. So how does hyperbarics work? So it exposes the patient to 100% oxygen in a supraatmospheric condition. So it actually decreases that half-life of carboxyhemoglobin to 30 minutes. Remember I said with the non-rebreather, it's 90 minutes. If they get hyperbarics, it's 30 minutes. It also does some things with the reactive oxygen species, which is why we think that it works to prevent that delayed neurologic sequelae. And it's associated with a decreased mortality after carbon monoxide poisoning, but the benefit has been most pronounced in patients that are less than 20 years old, which is not a lot of people in this room, right? And then those patients with acute respiratory failure, but it still works for everyone else. And it has a lower mortality if patients get more than one treatment. There are some challenges with hyperbarics. There's a limited number of chambers available in the US. So I know UAB only has a handful, and the majority of them are single patient. So like this picture, only one patient can fit into the chamber. Some chambers exist that are multi-patient, but we don't have those in Alabama. And another problem is patients have to be pretty stable to go in this because you can't get to them quickly if you need to. So if a patient's intubated at UAB, they can't get hyperbarics. But obviously, if they need an airway, they need an airway. But you just can't get to them. So if they got a pneumothorax or if the ET tube moved, we can't get to them quick enough for them to go into the chamber. Or if they're on vasopressors for hypotension, we can't really fix that. So what about kids? So kids will usually present with more subtle symptoms. A toddler may be just fussy, maybe they don't want to eat well, and they develop symptoms generally faster than adults because they have a higher minute ventilation, a higher respiratory rate, and they use oxygen at a higher rate. But the incidence of that delayed neurologic sequelae is actually lower, and pediatric patients can get hyperbarics. And in pregnant patients, remember the carboxyhemoglobin is lower to use it in pregnant patients. So if it's greater than 15% versus the 25, it's because carbon monoxide will bind to fetal hemoglobin with a greater affinity than adult hemoglobin, and it has a longer half-life. All right, so what are long-term outcomes? So in patients that survive that initial poisoning, the morbidity is mostly related to the late neurocognitive impairment, so the DNS, that persists in up to 40% of patients. And that long-term mortality is actually increased if myocardial injury occurs. And then how do we prevent this? It's making sure that a gas generator is not put into a garage. They are not starting your vehicle in a closed garage or getting a carbon monoxide detector. They're pretty widely available, pretty inexpensive, but you have to make sure it's in working order. All right, so the summary, carbon monoxide can cause acute or chronic symptoms, and it's really a wide range of symptoms. It binds to hemoglobin with a greater affinity than oxygen, and it decreases oxygen delivery to tissues. So there's treatment available. The main thing that we can do in the field is non-rebreather, and then we can consider hyperbarics. I actually had a patient a couple months ago, I think it was last winter, there was 2 patients that came into UAB with altered mental status. They were in a trailer and they had a generator hooked up, go into their trailer, but they had the exhaust pipe going into the trailer. Yeah, so it was a good catch by the EMS team that brought them in that noticed it because they had carbon monoxide poisoning. The male patient was so altered that he was finding us. We couldn't do anything. We ended up having to intubate him, so he couldn't get hyperbarics. But the female patient was pretty calm, and she ended up getting hyperbarics. The bad thing is that they went home, they got discharged from the hospital, and did the same thing again, unfortunately. All right, any questions on carbon monoxide? Yeah, any questions online? Okay, all right, we're going to talk about cyanide now. All right, so what is cyanide? So cyanide is a mitochondrial toxin. So remember I said the mitochondria is the powerhouse or the workhouse of the cell. So it makes all your energy. And cyanide is rapidly lethal within minutes to hours of an exposure. And from 2015 to 2019, there were about 885 exposures with 16 fatalities. And I can at least recall one that came into UAB not too long ago. That was a patient that was involved in a fire who was in cardiac arrest when EMS got to him. They, did everything they could, continued the code till they got to the hospital. UAB gave him hydroxycobalamin, immediately got ROSC. Long-term outcome wasn't great because he had been down for so long, but that's when we need to think about this. All right, so there's several different sources of exposure. So the predominant one we're going to see is those fire-related exposures. So it occurs when there's combustion of products that contain both carbon and nitrogen. So think if a house has wool in it, silk, upholstery, insulation, any kind of plastics, household goods, rubber. And cyanide levels are found in about 35% of victims. It can also be found in medical treatment. So certain cancer treatments have cyanide. And then the more common one we see in the hospital is sodium nitroprusside. Has anyone ever heard of that? So it's a medicine that is used in some hospitals, less used now, but it's for hypertensive emergency. It can also be found in certain industrial sources, so metal extraction, electroplating and jewelry production, certain photography, and then it's in rodent pesticide. It can be found in certain foods, so bitter almonds. It's in the pit of some fruits, so cherries, apricots, peaches, plums. And then there's cyanide salts that exist. And this is whenever you usually see those patients that die of cyanide toxicity because they committed suicide with a cyanide salt. And it's also found in tobacco. All right, so how does it work? So cyanide gets into your mitochondria. And in your mitochondria, you have something called the electron transport chain. Anybody remember that? Yeah. So it makes the majority of your energy. We're not going to get in the weeds of this. It makes the majority of your energy for a cell. And what cyanide does is it activates this enzyme, the cytochrome oxidase. And so it inhibits the electron transport chain from making your oxygen or making your ATP. And the electron transport chain uses oxygen in it. So you still have the oxygen available. You're just not making the energy anymore. And so this prevents you from being able to use aerobic respiration, which is using oxygen. You have to switch to anaerobic metabolism, which can produce a lactic acidosis. So this is just a better example. So on the left, there's the aerobic metabolism, which the oxidative phosphorylation is what makes the majority of your ATP. And this is what cyanide inhibits. And whenever you inhibit that, you have to use anaerobic metabolism, which is on the right. And that uses glucose for energy. And it eventually breaks down into lactic acid, which is why these patients get a very profound lactic acidosis. All right. So like I said, you still have oxygen available, but the cells can't use it because they can't use the electron transport chain. So it kind of results in a functional hypoxia, and that's bad for your brain, your spinal cord, your heart, your lungs. And then a small amount of cyanide will bind to hemoglobin like the carbon monoxide does, and it forms cyanohemoglobin. So what are some signs and symptoms, the things that we should look for? So patients can look like carbon monoxide poisoning. They may present with a headache, confusion. They may lose consciousness, seizures. These patients initially may be tachycardic and hypertensive, and then after some time, they'll actually get hypotensive and bradycardic. They may have an increased respiratory rate initially, and then they'll have a low respiratory rate. They can present with pulmonary edema, vomiting, abdominal pain. They may have flushing. Their skin may be red. They say the cherry red discoloration of the skin, especially after death, which is what this picture is. They can present with kidney failure, rhabdo, liver necrosis, and then patients might smell a bitter almond smell. And the things that we're looking for really depends on the route that the patient gets exposed, the dose, and the duration. So if it's inhalational, like we're more likely to see in the field from a fire, the toxicity can occur within minutes. So it's that patient that was in a fire who is in cardiac arrest when you get to them. Or if it's ingestion, so those cancer treatments, certain medical treatments, foods, that's usually delayed more minutes to hours. And then it also has a delayed sequelae, which kind of looks like Parkinson's. That's more acute exposures, but if you have more of a chronic exposure, the patients may present with headache, abnormal taste, vomiting, chest pain, abdominal pain, anxiety. And then there's 3 syndromes, which I'm not going to really go over, that can be associated with more chronic long-term exposures, and they predominantly cause vision problems. So how do we diagnose this? So it's really pretty uncommon, right? Remember I said there's only like 885 cases in 4 years in the US. But we need to think about it if a patient is a victim of a fire, they had smoke inhalation, if we know that they had some sort of ingestion, if they work and do mining, if they do electroplating and jewelry, we need to consider this. And when we get to the hospital, a blood cyanide level is not helpful at all. We can get it, but it probably takes a week to come back. And by the time we get that back, that patient's going to be dead, right? If we didn't treat them. So how do we manage these patients? So we got to make sure that we're managing them because untreated, it's really pretty fatal and fatal quickly. So we need to focus on resuscitating these patients, trying to decontaminate them, get them away from their exposure. If for some reason it's something that's on their clothes, try to get their clothes off of them, keep them covered. Focus on their ABCs. If they need an airway, give it to them. If they need fluids, give it to them. If they're seizing, give them benzos. We need to give these patients high flow oxygen, just like carbon monoxide, because they may have carbon monoxide poisoning as well, or just to help with that functional hypoxia that I talked about. And then if we really think that it's cyanide, we need to give them the antidote. So there's the main antidote that we use now is hydroxycobalamin, but there's really 3 mechanisms that antidotes can work for cyanide poisoning. So there's one, hydroxycobalamin directly binds to cyanide. There's another medicine that induces a methemoglobinemia, and then another medicine that uses sulfur donors. But we're mostly going to talk about the hydroxycobalamin. So it directly binds to cyanide. You can actually give this in the field if you have it available. That for that cardiac arrest from a fire or smoke inhalation, you can give this. So it's usually 5 grams in an adult. And don't be surprised if they turn purple red, like a purple red color. So this is somebody's urine on the left before hydroxycobalamin, and on the right is after. It just turns everything purple or red. And the hydroxycobalamin will directly bind to the cyanide, form cyanocobalamin, and then that gets excreted in your urine. This can interfere with, like I said, the carbon monoxide, the carboxyhemoglobin levels. So if you do give it in the field, make sure you let the team know in the hospital in case they try to measure the carboxyhemoglobin, that it's not going to be a right measurement. And then you can use sodium nitrate to induce methemoglobinemia. Some hospitals have this, but it's not the preferred treatment anymore because methemoglobinemia can be bad too. And the treatment for methemoglobinemia is methylene blue. But if you give methylene blue, it can also cause release of cyanide. So, and then you can use sodium thiosulfate, which uses sulfur donors to try to detoxify the cyanide. So before hydroxycobalamin was the preferred treatment, there was the Lilly kit, if any of y'all remember that had amyl nitrate, sodium thiosulfate in it. The amyl nitrate's actually not manufactured in the US anymore or recommended. All right, so what about kids? So kids present similarly to adults, but they are more vulnerable to cyanide because they're more immature, they have a higher respiratory rate, a higher minute ventilation, and a lower body mass. But they can still get hydroxycobalamin. All right, so summary for cyanide, it halts the aerobic respiration. So you're forced to have anaerobic respiration, which uses glucose to make lactic acid, which is why these patients get a really high lactic acid. Can cause a wide range of symptoms that are similar to carbon monoxide poisoning. Antidotes exist, but we need to make sure we're giving these patients oxygen and then considering hydroxycobalamin. All right, any questions?
Hey, Dr. Brown, we had a question come in online about SpO2 false high readings, and could you explain why that happens or under what circumstances that might happen?
So with the carbon monoxide poisoning or cyanide, you still have oxygen available. So the oxygen, the pulse ox, is not going to be correct. So with carbon monoxide or cyanide, you have this functional hypoxia. So you're not really delivering oxygen to the peripheral tissues, but that's not what the pulse ox is measuring. It's measuring how much PO2, like how much oxygen is available. And the oxygen is still available. It's just not being used properly. So it's going to give you a false high reading. There are some available pulse oxes for carbon monoxide that measure carboxyhemoglobin, but they're not widely available. We don't have them at UAB.
Yeah, actually, I think if you use the rainbow system, which a lot of EMS organizations do on their life packs, then it switches over to SPCO at a certain level. But if it's pulse oximetry, it's pulse oximetry, and you're going to get the false high readings. Is that correct? So we had another question come in. Do you recommend the use of cyano kit for every cardiac arrest at a fire scene?
I think it probably depends. I think especially if the patient does not appear to have significant burns, you know, if they have 100% burns to their body, their outcome is going to be not great. But if you have hydroxycobalamin available, you can give it, but it is very expensive. And generally, if a service has it or an agency has it, it's probably one, and it's probably on a supervisor's truck or vehicle. I would say if you think that it's survivable, I would definitely give it if they don't have significant burns, or if they do have some burns, but they're likely survivable, I would give it. What do you think, Dr. Ferguson?
Yeah, I think if there's it's not good. Yeah, so I think if the patient has a high risk of survivability, you give it. So if there are no traumas, they're in PEA, but respiratory arrest, yeah, manage your airway, give the cyano kit. If there's other trauma and they're burned, they're probably going to not survive anyway. Who's carrying cyano kit now? Anybody want to admit to it? Yeah. How much does it cost? Yeah, $800. That's a good deal. I'm going to talk to you later. So that's a good price. Yeah, pretty expensive. I think if you're fire-based, you ought to carry it as a safety measure for your crews. Obviously, we give it to our citizens that need it as well, but it is expensive, and you got to just do risk to benefit financially as well. So super sick people, hypoxic, working hard to breathe with the risk of cyano poisoning, they get cyano kit.
I agree. Any other questions online or in the audience?
Sure. All right. Thanks, guys. Hey, remember EMS Challenge the 2nd and 4th Wednesday of each month. We stream it live. We got EMS Con Ed. There's free nursing Con Ed. Hopefully by February, we'll have CME for physicians and APPs that is free as well. Skill labs twice a month. Got a cadaver lab coming up December 9th at UAB, and we do another one in the spring. So all this is free. If you need us, reach out. Thanks to the Fire College for sponsoring us, and thanks to the state conference for letting us come down. So